Dr. Sushrutha Dissanayake.
Hello, hi. Hold on a second, let me share my screen. Right, I hope you can see the screen. All right, yes. Thank you. So I'm Dr. Sushrutha Dissanayake. I'm one of the VR surgeons in Sri Lanka. I'm working in the northernmost teaching hospital of Sri Lanka, the Retinal teaching hospital. Slides. Okay, so now we all know in our region, the healthcare facilities are oversubscribed. We have overburdened healthcare services, limited healthcare service provision capabilities, and our screening services are limited. We can't screen as well as the developed countries do. And our transport services are limited, and also the patient's health-seeking behavior is limited for various reasons. So now this was before COVID, and after COVID, things got a little worse. And because our limited healthcare services, we had to give priority to COVID. And there was also the risk of contracting COVID when you come to hospital or take public transport. And especially we deal with high-risk population. And I noticed in Sri Lanka, there was a misinterpretation of lockdown rules. People thought during lockdown, you're not even allowed to go to the hospital, even if you have a sudden loss of vision. So there were lots of problems that that came with the COVID and made things worse. So this is a story. This is a typical story of a patient which you get these days. This is a 62-year-old lady who was otherwise healthy, and she had a sudden loss of vision following flashes and floaters in the right eye about 4 months ago. But the country was in lockdown. So instead, she went to the local temple and asked the priest, and he had given an oil to apply on the forehead and the scalp. So she was putting this, and she waited for 2 more weeks and before she could go to the local hospital. So overall, she had waited about 6 weeks. And when she went to the local hospital, a retinal detachment was diagnosed, and she was later transferred for VR services. And there was a subtotal retinal detachment on a phakic cataractous eye. And she had combined phakic lensectomy and intraocular lens implantation, TPPV, and oil for RT surgery. But at 3 weeks, she was found to be detaching inferiorly under oil. So when it comes to hematogenous retinal detachments, we have the patients nowadays present with higher levels of PVR than they used to because of the delayed presentation. And they also have higher percentage of contracted retinas, lower functioning RPE, and lower functioning ciliary body. So they come with soft eyes more often than not. And we also find higher amounts of neovascularization on the iris and angles. There was a reduction of patients coming with retinal detachment due to trauma or air travel. You know, air travel, lots of patients after air travel, sometimes we get a lot of people coming with floaters, but that has gone down simply because the air travel has gone down. So now we are doing more combined procedures because the retinal detachments are more complicated. We are doing external buckling along with vitrectomy, phacolensectomy along with vitrectomy, and we also tend to use more silicone oil for tamponade and longer use of silicone oil. We do more laser, more extensive laser, and despite that, there's a lot of redetachment. So we do redetachment surgeries also more often than before, and we deal with secondary glaucoma, and the visual output is also low. But on the other hand, the emergency cases have gone down because everyone is delayed now. And it's a similar story for tractional RT. The patients have more extensive diabetic membranes and neovascularization, and lower levels of PRP, thicker and stronger membranes, and there's higher retinal ischemia when we, even after reattaching the retina, the function is very poor because of that. higher levels of neovascular glaucoma, and more macular pucker. And we also have to deal with a lot of patients with vitreous hemorrhages, and we get surprises when we clear the vitreous hemorrhage. There's extensive retinal detachment, tractional arteries with extensive membranes. Here again, we do prolonged surgeries in case of complications because of these thick membranes. Sometimes when you're cutting the membranes, the retina gets damaged, so then we have to deal with that. And there's more bleeding, and we use higher amounts of buckling, encircling bands, and we use more laser and anti-VEGF. And again, silicone oil tamponade is longer, and sometimes because the membranes are thicker, we have to sometimes leave them behind. So the amounts of membranes left behind is also higher. So overall, we have become, after COVID, we have become more defensive in prognostication. We don't promise, we can't promise much to the patients because of the more complicated nature of these detachments. And we have become less hesitant to perform secondary procedures and more complex procedures simply because we don't have much choice. But we need to think about the future. So now, because of this, the change in presentation, have we become less cautious during surgery? Even if you do a perfect surgery, sometimes the visual outcome is poor. So therefore, are we becoming less careful? And the other thing is now we need to take more time to do surgeries. So can we handle the same number of cases as before COVID? So, so we need to modify the lists as well. And the third question, such as patients not willing to come to hospitals because they think they'll get COVID. The health education is poor in our region. We need to educate them so that their health-seeking behavior is improved. And the other thing is accessibility. We have limited number of hospitals, limited number of VR surgeons, limited number of theater. And on top of that, we have limited number of equipment and consumables. So we need to increase that as well if we are going to look into the future post-COVID. Thank you very much.
Thank you, Dr.